Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Association of Socioeconomic Status, Sex, Racial, and Ethnic Identity with Sustained and Cultivated Careers in Surgery. Objective: examine the association between sex, race, ethnicity, and family income, and the intersectionality between these identities, and sustained or cultivated paths in surgery and medical school. Methods. This retrospective cohort study examines U.S. medical students who matriculated in academic years 2014 to 2015 and 2015 to 2016. Data were provided by the Association of American Medical Colleges, including self-reported sex, race, ethnicity, family income, interest in surgery at matriculation, and successful placement into a surgical residency at graduation. This study examined two outcomes: 1. Sustained path in surgery between matriculation and graduation for students who entered medical school with an interest in surgery, and 2. Cultivated path in surgery for students who entered medical school not initially interested in surgery and who applied to and were successfully placed into a surgical residency at graduation. Results. Among the 5,074 students who reported interest in surgery at matriculation, 2,108, 41.5%, had sustained path in surgery. Compared to male students, female students were significantly less likely to have sustained path in surgery, adjusted relative risk, R, 0.92, 0.85 to 0.98, while Asian, R, 0.82, 95% C, 0.74 to 0.91, Hispanic, R, 0.70, 95% C, 0.59 to 0.83, and low income, R, 0.85, 95% C, 0.78 to 0.92. Students were less likely to have a sustained path in surgery compared to their peers. Among the 17,586 students who reported an initial interest in a non-surgical specialty, 1869, 10.6%, were placed into a surgical residency at graduation. Female students, regardless of race/ethnic identity and income, were significantly less likely to have cultivated paths in surgery compared to male students, with underrepresented in medicine female students reporting the lowest rates. Conclusions and relevance. This study demonstrates the significant disparity in sustained and cultivated paths in surgery during undergraduate medical education. Innovative transformation of the surgical learning environment to promote surgical identity development and belonging for females, underrepresented in medicine, and low-income students is essential to diversify the surgical workforce. Impact of community socioeconomic distress on survival following heart transplantation. Objective. The aim of this study was to assess the impact of community-level socioeconomic deprivation on survival outcomes following heart transplantation. Background. Despite growing awareness of socioeconomic disparities in the U.S. healthcare system, significant inequities in outcomes remain. While recent literature has increasingly considered the effects of structural socioeconomic deprivation, the impact of community socioeconomic distress on outcomes following heart transplantation has not yet been elucidated. Methods. All adult heart transplant recipients from 2004 to 2022 were ascertained from the Organ Procurement and Transplantation Network. Community socioeconomic distress was assessed using the previously validated Distressed Communities Index, a metric that represents education level, housing vacancies, unemployment, poverty rate, median household income, and business growth by zip code. Communities in the highest quintile were considered the distressed cohort, others, non-distressed. Outcomes were considered across two eras, 2004 to 2018 and 2019 to 2022, to account for the 2018 UNOS policy change. 3 and 5 year patient and graft survival were assessed using Kaplan-Meier and Cox proportional hazards models. Results: of 36,777 heart transplants, 7,450, 20%, were considered distressed. Following adjustment, distressed recipients demonstrated a greater hazard of 5-year mortality from 2004 to 2018, hazard ratio, HR equals 1.10, 95% confidence interval, C, 1.03 to 1.18, P equals 0.005, and 3-year mortality from 2019 to 2022, HR equals 1.29, 95% C, 1.10 to 1.51, P equals 0.002, relative to non-distressed. Similarly, the distressed group was associated with increased hazard of graft failure at 5 years from 2004 to 2018, HR equals 1.10, 95% C, 1.03 to 1.18, P equals 0.003, and at 3 years from 2019 to 2022, HR equals 1.31, 95% C, 1.11 to 1.53, P equals 0.001. Conclusions: community-level socioeconomic deprivation is linked with inferior patient and graft survival following heart transplantation. Future interventions are needed to address pervasive socioeconomic inequities in transplantation outcomes. The association of cannabis use after discharge from surgery with opioid consumption and patient-reported outcomes. Objective: to compare outcomes of patients using versus not using cannabis as a treatment for pain after discharge from surgery. Background: cannabis is increasingly available and is often taken by patients to relieve pain. However, it is unclear whether cannabis use for pain after surgery impacts opioid consumption and postoperative outcomes. Methods: using Michigan Surgical Quality Collaborative Registry data at 69 hospitals, we analyzed a cohort of patients undergoing 16 procedure types between January 1, 2021, and October 31, 2021. The key exposure was cannabis use for pain after surgery. Outcomes included post-discharge opioid consumption, primary, and patient-reported outcomes of pain, satisfaction, quality of life, and regret to undergo surgery, secondary. Results: of 11,314 included patients, 58% females, mean age, 55.1 years, 581, 5.1%, reported using cannabis to treat pain after surgery. In adjusted models, patients who used cannabis consumed an additional 1.0, 95% C, 0.4 to 1.5, opioid pills after surgery. Patients who used cannabis were more likely to report moderate to severe surgical site pain at 1 week, adjusted odds ratio, 1.7, 95% SIL 1.4 to 2.1, and 1 month, adjusted odds ratio, 2.1, 95% C, 1.7 to 2.7, after surgery. Patients who used cannabis were less likely to endorse high satisfaction, 72.1% versus 82.6%, best quality of life, 46.7% versus 63.0%, and no regret, 87.6% versus 92.7%, all p less than 0.001. Conclusions: patient-reported cannabis use, to treat postoperative pain, was associated with increased opioid consumption after discharge from surgery that was of clinically insignificant amounts, but worse pain and other postoperative patient-reported outcomes. Postoperative outcomes after gastrointestinal surgery in patients receiving chronic kidney replacement therapy, a population-based cohort study. Objective: this study evaluated the postoperative mortality and morbidity outcomes following the different subtypes of gastrointestinal (GI) surgery over a 15-year period. Background: patients receiving chronic kidney replacement therapy (KRT) experience higher rates of general surgery compared with other surgery types. Contemporary data on the types of surgeries and their outcomes are lacking. KRT was defined as patients requiring chronic dialysis, hemodialysis or peritoneal dialysis, or having a functioning kidney transplant long-term. Methods: all incident and prevalent patients aged greater than 18 years identified in the Australia and New Zealand Dialysis and Transplant ANSTATA, registry is receiving chronic KRT were linked with jurisdictional hospital admission datasets between January 1, 2000 until December 31, 2015. Patients were categorized by their KRT modality: hemodialysis, HD, peritoneal dialysis, PD, home hemodialysis, HHD, and kidney transplant, KT. GI surgeries were categorized as upper gastrointestinal, UGI, bowel, small and large bowel, anorectal, hernia surgery, cholecystectomy, and appendectomy. The primary outcome was the rates of the different surgeries, estimated using Poisson models. Secondary outcomes were risks of 30-day in-hospital postoperative mortality risk and non-fatal outcomes and were estimated using logistic regression. Independent predictors of 30-day mortality were examined using comorbidity-adjusted Cox models. Results: overall, 46,779 patients on chronic KRT were linked to jurisdictional hospital datasets, and 9,116 patients were identified as having undergone 14,540 GI surgeries with a combined follow-up of 76,593 years. Patients on PD had the highest rates of GI surgery, 8 per 100 patient years, with hernia surgery being the most frequent. Patients on PD also had the highest risk of 30-day postoperative mortality following the different types of GI surgery, with the risk being more than twofold higher after emergency surgery compared with elective procedures. Infective postoperative complications were more common than cardiac complications. This study also observed a U-shaped association between body mass index, BMI, and mortality, with a nadir in the 30 to 35 kg/m2 group. Conclusions: patients on chronic KRT have high rates of GI surgery and morbidity, particularly in those who receive PD, are older, or are either underweight or moderately obese. A prognostic model to predict survival after recurrence among patients with recurrent hepatocellular carcinoma. Objective: we sought to develop and validate a preoperative model to predict survival after recurrence, SAR, in hepatocellular carcinoma, HCC. Background: although HCC is characterized by recurrence as high as 60%, models to predict outcomes after recurrence remain relatively unexplored. Methods: patients who developed recurrent HCC between 2000 and 2020 were identified from an international multi-institutional database. Clinicopathologic data on primary disease and laboratory and radiologic imaging data on recurrent disease were collected. Multivariable Cox regression analysis and internal bootstrap validation, 5,000 repetitions, were used to develop and validate the SAR score. Optimal survival tree analysis was used to characterize SAR among patients treated with various treatment modalities. Results: among 497 patients who developed recurrent HCC, median SAR was 41.2 months, 95% C38.1 to 52.0. The presence of cirrhosis, number of primary tumors, primary macrovascular invasion, primary R1 resection margin, AFP greater than 400 nanograms per milliliter on the diagnosis of recurrent disease, radiologic extrahepatic recurrence, radiologic size and number of recurrent lesions, radiologic recurrent bilobar disease, and early recurrence, less than or equal to 24 months, were included in the model. The SAR score successfully stratified 1, 3 and 5-year SAR and demonstrated strong discriminatory ability, 3-year AUC 0.75, 95% C 0.70 to 0.79. While a subset of patients benefited from resection/ablation, optimal survival tree analysis revealed that patients with high SAR score disease had the worst outcomes, 5-year AUC, training, 0.79 versus testing, 0.71. The SAR score model was made available online for ease of use and clinical applicability. https://utakaendo.shinyaps.io/sarscore/. Conclusion: the SAR score demonstrated strong discriminatory ability and may be a clinically useful tool to help stratify risk and guide treatment for patients with recurrent HCC. Next article is from Journal of American Medical Association Surgery. Glucagon-like peptide 1 receptor agonist use and residual gastric content before anesthesia. Importance: Glucagon-like peptide 1 receptor agonist, GLP-1RA, use is rapidly increasing in the U.S., driven by its expanded approval for weight management in addition to hyperglycemia management in patients with type 2 diabetes. The perioperative safety of these medications, particularly with aspiration risk under anesthesia, is uncertain. Objective: to assess the association between GLP-1RA use and prevalence of increased residual gastric content, RGC, a major risk factor for aspiration under anesthesia, using gastric ultrasonography. Design, setting, and participants: this cross-sectional study prospectively enrolled patients from a large, tertiary, university-affiliated hospital from June 6 through July 12, 2023. Participants followed pre-procedural fasting guidelines before an elective procedure under anesthesia. Patients with altered gastric anatomy, e.g., from previous gastric surgery, pregnancy, recent trauma, less than 1 month, or an inability to lie in the right lateral decupitous position for gastric ultrasonography were excluded. Exposure: use of a once-weekly GLP-1RA. Main outcomes and measures: the primary outcome was the presence of increased RGC, defined by the presence of solids, thick liquids, or more than 1.5 ml/kg of clear liquids on gastric ultrasonography. Analysis was adjusted for confounders using augmented inverse probability of treatment weighting, a propensity score-based technique. Secondarily, the association between the duration of drug interruption and the prevalence of increased RGC was explored. Results: among the 124 participants, median age, 56 years, IQR, 46 to 65 years, 75, 60%, female, the prevalence of increased RGC was 56%, 35 of 62, in patients with GLP-1RA use, exposure group, compared with 19%, 12 of 62, in patients who were not taking a GLP-1RA drug, control group. After adjustment for confounding, GLP-1RA use was associated with a 30.5%, 95% C, 9.9% to 51.2%, higher prevalence of increased RGC, adjusted prevalence ratio, 2.48, 95% C, 1.23 to 4.97. There was no association between the duration of GLP-1RA interruption and the prevalence of increased RGC, adjusted odds ratio, 0.86, 95% C, 0.65 to 1.14. Conclusions and relevance: use of a GLP-1RA was independently associated with increased RGC on pre-procedural gastric ultrasonography. The findings suggest that the pre-procedural fasting duration suggested by current guidelines may be inadequate in this group of patients at increased risk of aspiration under anesthesia. Next, we will be discussing articles from British Journal of Surgery. Impact of a non-therapeutic laparotomy in patients with locally advanced pancreatic cancer treated with induction, FOLFIRINOX, Transatlantic Pancreatic Surgery, TAPS, Consortium Study. Background: surgery in selected patients with locally advanced pancreatic cancer after induction chemotherapy may have drawbacks related to surgical risks and breaks or delays in oncological treatment, in particular when curative intent resection is not possible, that is, non-therapeutic laparotomy. The aim of this study was to assess the incidence and oncological impact of a non-therapeutic laparotomy in patients with locally advanced pancreatic cancer treated with induction, FOLFIRINOX chemotherapy. Methods: this was a retrospective international multi-center study including patients diagnosed with pathology-proven locally advanced pancreatic cancer treated with at least one cycle of FOLFIRINOX, 2012 to 2019. Patients undergoing a non-therapeutic laparotomy, Group A, were compared with those not undergoing surgery, Group B, and those undergoing resection, Group C. Results: overall, 663 patients with locally advanced pancreatic cancer were included, 67 patients, 10.1%, in Group A, 425 patients, 64.1%, in Group B, and 171 patients, 25.8%, in Group C. A non-therapeutic laparotomy occurred in 28.2% of all explorations, 67 of 238, with occult metastases in 30 patients, 30 of 67, 44.8%, and a 90-day mortality rate of 3.0%, 2 of 67. Administration of palliative therapy, 65.9% versus 73.1%, T equals 0.307, and median overall survival, 20.4, 95% CI 15.9 to 27.3, versus 20.2, 95% CI 19.1 to 22.7, months, P equals 0.752, did not differ between Group A and Group B respectively. The median overall survival in Group C was 36.1, 95% CI 30.5 to 41.2, months. The 5-year overall survival rates were 11.4%, 8.7%, and 24.7% in Group A, Group B, and Group C, respectively. Compared with Group B, non-therapeutic laparotomy, Group A, was not associated with reduced overall survival, HR equals 0.88, 95% CI 0.61 to 1.27. Conclusion. More than a quarter of surgically explored patients with locally advanced pancreatic cancer after induction, FOLFIRINOX did not undergo a resection. Such non-therapeutic laparotomy does not appear to substantially impact oncological outcomes. Next we will be discussing articles from Journal of Vascular Surgery. Early and midterm outcomes of fenestrated and branched endovascular aortic repair and thoracoabdominal aneurysms types I through 3. Background. Fenestrated and branched endovascular aortic repair, F/BEVR, of thoracoabdominal aortic aneurysms, TIS, has shown high technical success and low early mortality rates. Aneurysm extent has been reported as a factor affecting outcomes. This study aimed to assess the early and midterm follow-up outcomes of patients managed by F/BEVR for types I through 3 TIS. Methods. A single-center retrospective analysis was conducted, including data from consecutive, elective and urgent, symptomatic and ruptured cases, patients treated for types I through 3 TIS, between October 1, 2011, and October 1, 2022, using F/BEVR. Degenerative and post-dissection TIS were included. Patients received prophylactic cerebrospinal fluid drainage, CSFD, except those under therapeutic anticoagulation, those who were hemodynamically unstable, or those with failed CSFD application. Results. F/BEVR for types I through 3 TIS was performed in 209 patients, 56.9% males, mean age, 69.6 plus or minus 3.2 years, mean aneurysm diameter, 65.2 plus or minus 6.2 millimeters, 29.2% type I, 57.9% type 2, and 12.9% type 3. Urgent repair was performed in 26.7% of patients, 56 cases, 23 ruptured and 33 symptomatic cases, and 153 were treated electively. 32 patients, 15.3%, were classified as American Society of Anesthesiologists, ASA, Class 4. CSFD was used in 91% and staged thoracic endovascular aortic repair was performed in 51.2% of patients. Technical success was 93.8%, 96.7% in elective versus 94.6% in urgent cases, p equals 0.92. 30-day mortality was 11.0%, 4.6% in elective versus 28.5% in urgent cases, p less than 0.001, and MAYs were recorded in 17.2% of cases, 7.8% in elective versus 42.8% in urgent cases, p less than 0.001. Spinal cord ischemia rate was 20.5%, 17.6% in elective versus 28.7% in urgent cases, p equals 0.08, whereas 2.9% of patients presented paraplegia, 1.3% in elective and 7.1% in urgent cases, p equals 0.03. The mean follow-up was 16 plus or minus 5 months. Survival was 75.0%, standard error, 4.0%, and freedom from reintervention was 73.3%, standard error, 4.4%, at 36 months. ASA4 and urgent repair were detected as independent factors related to early mortality in May, whereas ruptured aneurysm status was related to spinal cord ischemia evolution. Conclusions. Endovascular repair for types I through 3 TAS provides encouraging early outcomes in terms of mortality, MAE, and paraplegia, especially in an elective setting. Setting of repair and baseline ASA score should be taken into consideration during decision-making. Long-term functional outcomes of upper extremity civilian vascular trauma. Objective: civilian analyses of long-term outcomes of upper extremity vascular trauma, UEVT, are limited. Our goal was to evaluate the management of UAVT in the civilian trauma population and explore the long-term functional consequences. Methods: a retrospective review and analysis was performed of patients with UAVT at an urban Level 1 trauma center, 2001 to 2022. Management and long-term functional outcomes were analyzed. Results: there were 150 patients with UAVT. Mean age was 34 years, and 85% were male. There were 42% Black and 27% white patients. Mechanism was penetrating in 79%, blunt in 20%, and multifactorial in 1%. Within penetrating trauma, mechanism was from firearms in 30% of cases. Of blunt injuries, 27% were secondary to falls, 13% motorcycle collisions, 13% motor vehicle collisions, and 3% crush injuries. Injuries were isolated arterial in 62%, isolated venous in 13%, and combined in 25% of cases. Isolated arterial injuries included brachial, 34%, radial, 27%, ulnar, 27%, axillary, 8%, and subclavian, 4%. The majority of arterial injuries, 92%, underwent open repair with autologous vein bypass, 34%, followed by primary repair, 32%, vein patch, 6.6%, and prosthetic graft, 3.3%. There were 23% that underwent fasciotomies, 68% of which were prophylactic. 2 patients were managed with endovascular interventions, 1 underwent covered stent placement and the other embolization. Perioperative reintervention occurred in 12% of patients. Concomitant injuries included nerves, 35%, bones, 17%, and ligaments, 16%. Intensive care unit admission was required in 45%, with mean intensive care unit length of stay 1.6 days. Mean hospital length of stay was 6.7 days. Major amputation and in-hospital mortality rates were 1.3% and 4.6% respectively. The majority, 72%, had greater than 6-month follow-up, with a median follow-up period of 197 days. Trauma readmissions occurred in 19%. Many patients experienced chronic pain, 56%, as well as motor, 54%, and sensory, 61%, deficits. Additionally, 41% had difficulty with activities of daily living. Of previously employed patients, 57%, 39% experienced a greater than 6-month delay in returning to work. Most patients, 82%, were discharged with opioids. Of these, 16% were using opioids at 6 months. Conclusions: UAVT is associated with long-term functional impairments and opioid use. It is imperative to counsel patients prior to discharge and ensure appropriate follow-up and therapy. Modified Harborview Risk Score accurately predicts mortality for patients with ruptured abdominal aortic aneurysm. Objective: the Modified Harborview Risk Score, HRS, is a simple measure initially derived from a single institutional dataset used to predict ruptured abdominal aortic aneurysm, RAA, repair survival preoperatively using basic labs and vital signs collected upon presentation. However, validation of this widely applicable scoring system has not been performed. This study aims to validate this scoring system using a large multi-institutional database. Methods: all patients who underwent repair of NRAA from 2011 to 2018 in the National Surgical Quality Improvement Program, SCUP, and at a single academic medical center were included. The modified hours was calculated by assigning 1 point for each of the following: age greater than 76 years, creatinine greater than 2 mg/dl, international normalized ratio greater than 1.8, and any systolic blood pressure less than 70 mm of mercury. Assessment of the prediction model was then completed. Using a primary outcome measure of 30-day mortality, the receiver operating characteristic area under the curve was calculated. The discrimination between datasets was compared using a DeLong test. Mortality rates for each score were compared between datasets using the Pearson-Chi-2 test. Comparative analysis for patients with a score of 4 was limited due to a small sample size. Results: a total of 1,536 patients were identified using SCUP, and 163 patients were assessed in the institutional dataset. There were 518 patients with a score of 0, 455 in SCUP, 63 institutional, 676 patients with a score of 1, 617 SCUP, 59 institutional, 391 patients with a score of 2, 364 in SCUP, 27 institutional, 106 with a score of 3, 93 in SCUP, 13 institutional, and 8 patients with a score of 4, 7 SCUP, 1 institutional. No difference was found in the receiver operating characteristic area under the curves between datasets, p equals 0.78. 30-day mortality was 10% in SCUP versus 22% institutional for a score of 0, 28% in SCUP versus 36% institutional for a score of 1, 41% in SCUP versus 44% institutional for a score of 2, 45% in SCUP versus 69% institutional for a score of 3, and 57% in SCUP versus 100% institutional for a score of 4. Score 0 was the only score with a significant mortality rate difference between datasets, p equals 0.01. Conclusions: the modified hours is confirmed to be broadly applicable as a clinical decision-making tool for patients presenting with RAS. Therefore, this easily applicable model should be applied for all patients presenting with RAS to assist with provider and patient decision-making prior to proceeding with repair. Safety and efficacy of mechanical aspiration thrombectomy for patients with acute lower extremity ischemia. Objective: acute limb ischemia, ALI, is associated with high rates of amputation and consequent morbidity and mortality. The objective of this study is to report on the safety and efficacy of aspiration thrombectomy using the Indigo aspiration system in patients with lower extremity, ALI. Methods: the STRIDE study was an international, multi-center, prospective study that enrolled 119 participants presenting with LAALI. Patients were treated first-line with mechanical thrombectomy using the Indigo aspiration system, before stenting or angioplasty, or other therapies as determined by treating physician. The primary endpoint was target limb salvage at 30 days after the procedure. Secondary endpoints within 30 days included technical success, defined as core laboratory adjudicated thrombolysis in myocardial infarction, TIMI 2/3 flow rate immediately after the procedure, changes in Modified Society for Vascular Surgery runoff score, improvement of Rutherford classification compared with before the procedure, patency, rate of device-related serious adverse events, and major periprocedural bleeding. Secondary endpoints that will be evaluated at 12 months include target limb salvage and mortality. Results: of the 119 participants enrolled at 16 sites, the mean age was 66.3 years, 46.2% female. At baseline, N equals 119, ischemic severity was classified as Rutherford I in 10.9%, Rutherford IA in 54.6%, and Rutherford IIB in 34.5%. The mean target thrombus length was 125.7 plus or minus 124.7 millimeters. Before the procedure, 93.0% of patients 107-115 had no flow, TIMI 0, through the target lesion. The target limb salvage rate at 30 days was 98.2%, 109-111. The rate of periprocedural major bleed was 4.2%, 5-119, and device-related serious adverse events was 0.8%, 1-119. Restoration of flow, TIMI 2/3, was achieved in 96.3% of patients, 105-109, immediately after the procedure. The median improvement in the Modified Society for Vascular Surgery runoff score before versus after the procedure was 6.0 interquartile range, 0.0 to 11.0. Rutherford classifications also improved after discharge in 86.5% of patients, 83.96, as compared with pre-procedural scores. Patency at 30 days was achieved in 89.4% of patients, 101-113. Conclusions. In the STRIDE, a study of patients with lower extremity acute limb ischemia to remove thrombus with the Indigo aspiration system, study, aspiration thrombectomy with the Indigo system provided a safe and effective endovascular treatment for patients with LALI, resulting in a high rate, 98.2%, of successful limb salvage at 30 days, with few periprocedural complications. Next article is from Surgical Endoscopy. Effect of sarcopenia on short-term and long-term outcomes of older patients with locally advanced gastric cancer, a multi-center study. Objective: to assess the effect of preoperative sarcopenia on the short-term and long-term outcomes in older patients with locally advanced gastric cancer, LAGC. Methods: clinicopathological data of older patients with LIC who underwent radical surgery were retrospectively analyzed. Sarcopenia was defined as a skeletal muscle index of less than 36.4 square centimeters/m2 for men and less than 28.4 square centimeters/m2 for women. Comparing the postoperative complications and survival between sarcopenia and non-sarcopenia groups using multi-center data. Results: a total of 406 older patients with LIC were included in the analysis, including 145, 35.7%, with sarcopenia and 261, 64.3%, with non-sarcopenia. Multivariate logistic regression analysis showed that sarcopenia was an independent risk factor for postoperative complications with CD grade greater than or equal to 2, or 1.616, p less than 0.05. Kaplan-Meier survival curve analysis showed that the 5-year overall survival, OS, and 5-year recurrence-free survival, RFS, in the sarcopenia group were lower than those in the non-sarcopenia group, p both less than 0.05. Multivariate Cox regression analyses showed that sarcopenia was an independent prognostic factor for 5-year OS and RFS, p both less than 0.05. The 5-year recurrence rate in the sarcopenia group was 57.2%, which was significantly higher than that in the non-sarcopenia group, 46.4%, p equals 0.036. Recurrence pattern analysis showed that the incidence of distant metastases in patients with sarcopenia, 42.8%, was significantly higher than non-sarcopenia, 31.4%, p equals 0.022. Conclusion: sarcopenia serves as a valuable predictor of both short-term and long-term outcomes in older patients with LIC. Therefore, the significance of assessing preoperative nutritional status and implementing thorough postoperative follow-up for older LIC patients with sarcopenia should be emphasized. Risk factor analysis of conversion in laparoscopic liver resection for intrahepatic cholangiocarcinoma. Background: the risk factors of patients with intrahepatic cholangiocarcinoma, ICC, requiring conversion to open surgery have not been adequately studied. This study aimed to determine the risk factors and postoperative outcomes of conversion in patients with ICC. Methods: from May 2014 to September 2022, unplanned conversions were compared with successful LLRs. Results: 153 patients with ICC initially underwent LLR, of which 41, 26.8%, required conversion to open surgery. Multivariate analysis for those factors that were statistically significant or confirmed by clinical studies, tumor proximity to the major vessels, or 6.643, p less than 0.001, and previous upper abdominal surgery, or 3.140, p equals 0.040, were independent predictors of unplanned conversions. Compared to successful LLRs, unplanned conversions showed longer operative times, 300.0 versus 225.0 minutes, p less than 0.001, more blood loss, 500.0 versus 200.0 milliliters, p less than 0.001, higher transfusion rates, 46.3% versus 11.6%, p less than 0.001, longer length of stays, 13.0 versus 8.0 days, p less than 0.001, and higher rates of major morbidity, 39.0% versus 11.6%, p less than 0.001. However, there was no statistically significant difference in 30-day or 90-day mortality between the conversion group and the laparoscopic group. Conclusion: conversion during LLR should be anticipated in ICC patients with prior upper abdominal surgery or tumor proximity to major vessels as features. Next article is from Annals of Surgical Oncology. Trends and determinants of location of death due to colorectal cancer in the United States. Background: colorectal cancer, CRC, is the second leading cause of cancer-related mortality in the United States, U.S. However, there are limited data on location of death in patients who die from CRC. We examined the trends in location of death and determinants in patients dying from CRC in the U.S. Methods: we utilize the Centers for Disease Control and Prevention wide-ranging online data for epidemiologic research database to extract nationwide data on underlying cause of death as CRC. A multinomial logistic regression was performed to assess associations between clinico-socio-demographic characteristics and location of death. Results: there were 850,750 deaths due to CRC from 2003 to 2019. There was a gradual decrease in deaths in hospital, nursing home, or outpatient facility/emergency department over time, and an increase in deaths at home and in hospice. Relative to white decedents, Black, Asian, and American Indian/Alaska Native decedents were less likely to die at home and in hospice compared with hospitals. Individuals with lower educational status also had a lower risk of dying at home or in hospice compared with in hospitals. Conclusions: the gradual shift in location of death of patients who die of CRC from institutionalized settings to home and hospice is a promising trend and reflects the prioritization of patient goals for end-of-life care by healthcare providers. However, there are existing socio-demographic disparities in access to deaths at home and in hospice, which emphasizes the need for policy interventions to reduce health inequity in end-of-life care for CRC. Next article is from Obesity Surgery. Is routine postoperative biological laboratory assessment necessary after sleeve gastrectomy? Background: incidence of postoperative complications after sleeve gastrectomy, SG, is low. However, the early identification of these complications remains crucial. Here, we report the impact of routine laboratory monitoring for the early diagnosis of complications after SG. Material and methods. From January 2018 to December 2019, all consecutive patients who underwent primary SG, N equals 457, were included. This was a comparative study of patients undergoing primary SG. Patients were divided into two groups, one group with routine laboratory monitoring performed at postoperative day, POD, 1 and 3, lab group, and another group without routine laboratory monitoring, control group. The study's primary endpoint was the overall impact of routine laboratory monitoring. The secondary endpoints were evaluation of patients with complications. Results: the population in the two groups were similar in terms of demographic and intraoperative data. There was a statistical difference between the two groups in terms of length of stay, 5.7 days in the lab group and 3.5 days in the control group, p less than 0.001. There were 19 complications, 6.0%, in the lab group and 5 complications in the control group, 3.5%, p equals 0.25. A cutoff C-reactive protein level of 46.3 mg/L was found to be significant, p equals 0.006. In the lab group, 9 patients, 2.9%, required readmission versus 3 patients, 2.0%, in the control group, p equals 0.62. Conclusion: the interest of routine laboratory monitoring after SG seems limited. Routine laboratory monitoring alone is not associated with earlier diagnosis of complications. This routine monitoring is associated with an increase of stay in hospital. Next article is from Obesity Surgery. Is routine postoperative biological laboratory assessment necessary after sleeve gastrectomy? Background: incidence of postoperative complications after sleeve gastrectomy, SG, is low. However, the early identification of these complications remains crucial. Here, we report the impact of routine laboratory monitoring for the early diagnosis of complications after SG. Material and methods. From January 2018 to December 2019, all consecutive patients who underwent primary SG, N equals 457, were included. This was a comparative study of patients undergoing primary SG. Patients were divided into two groups, one group with routine laboratory monitoring performed at postoperative day, POD, 1 and 3, lab group, and another group without routine laboratory monitoring, control group. The study's primary endpoint was the overall impact of routine laboratory monitoring. The secondary endpoints were evaluation of patients with complications. Results. The population in the two groups were similar in terms of demographic and intraoperative data. There was a statistical difference between the two groups in terms of length of stay, 5.7 days in the lab group and 3.5 days in the control group, p less than 0.001. There were 19 complications, 6.0%, in the lab group and 5 complications in the control group, 3.5%, p equals 0.25. A cutoff C-reactive protein level of 46.3 mg/L was found to be significant, p equals 0.006. In the lab group, 9 patients, 2.9%, required readmission versus 3 patients, 2.0%, in the control group, p equals 0.62. Conclusion. The interest of routine laboratory monitoring after SG seems limited. Routine laboratory monitoring alone is not associated with earlier diagnosis of complications. This routine monitoring is associated with an increase of stay in hospital. Next article is from Obesity Surgery. Is routine postoperative biological laboratory assessment necessary after sleeve gastrectomy? Background. Incidence of postoperative complications after sleeve gastrectomy, SG, is low. However, the early identification of these complications remains crucial. Here, we report the impact of routine laboratory monitoring for the early diagnosis of complications after SG. Material and methods. From January 2018 to December 2019, all consecutive patients who underwent primary SG, N equals 457, were included. This was a comparative study of patients undergoing primary SG. Patients were divided into two groups, one group with routine laboratory monitoring performed at postoperative day, POD, 1 and 3, lab group, and another group without routine laboratory monitoring, control group. The study's primary endpoint was the overall impact of routine laboratory monitoring. The secondary endpoints were evaluation of patients with complications. Results. The population in the two groups were similar in terms of demographic and intraoperative data. There was a statistical difference between the two groups in terms of length of stay, 5.7 days in the lab group and 3.5 days in the control group, p less than 0.001. There were 19 complications, 6.0%, in the lab group and 5 complications in the control group, 3.5%, p equals 0.25. A cutoff C-reactive protein level of 46.3 mg/L was found to be significant, p equals 0.006. In the lab group, 9 patients, 2.9%, required readmission versus 3 patients, 2.0%, in the control group, p equals 0.62. Conclusion. The interest of routine laboratory monitoring after SG seems limited. Routine laboratory monitoring alone is not associated with earlier diagnosis of complications. This routine monitoring is associated with an increase of stay in hospital. Next article is from Obesity Surgery. Is routine postoperative biological laboratory assessment necessary after sleeve gastrectomy? Background. Incidence of postoperative complications after sleeve gastrectomy, SG, is low. However, the early identification of these complications remains crucial. Here, we report the impact of routine laboratory monitoring for the early diagnosis of complications after SG. Material and methods. From January 2018 to December 2019, all consecutive patients who underwent primary SG, N equals 457, were included. This was a comparative study of patients undergoing primary SG. Patients were divided into two groups, one group with routine laboratory monitoring performed at postoperative day, POD, 1 and 3, lab group, and another group without routine laboratory monitoring, control group. The study's primary endpoint was the overall impact of routine laboratory monitoring. The secondary endpoints were evaluation of patients with complications. Results. The population in the two groups were similar in terms of demographic and intraoperative data. There was a statistical difference between the two groups in terms of length of stay, 5.7 days in the lab group and 3.5 days in the control group, p less than 0.001. There were 19 complications, 6.0%, in the lab group and 5 complications in the control group, 3.5%, p equals 0.25. A cutoff C-reactive protein level of 46.3 mg/L was found to be significant, p equals 0.006. In the lab group, 9 patients, 2.9%, required readmission versus 3 patients, 2.0%, in the control group, p equals 0.62. Conclusion. The interest of routine laboratory monitoring after SG seems limited. Routine laboratory monitoring alone is not associated with earlier diagnosis of complications. This routine monitoring is associated with an increase of stay in hospital. Next article is from Obesity Surgery. Is routine postoperative biological laboratory assessment necessary after sleeve gastrectomy? Background. Incidence of postoperative complications after sleeve gastrectomy, SG, is low. However, the early identification of these complications remains crucial. Here, we report the impact of routine laboratory monitoring for the early diagnosis of complications after SG. Material and methods. From January 2018 to December 2019, all consecutive patients who underwent primary SG, N equals 457, were included. This was a comparative study of patients undergoing primary SG. Patients were divided into two groups, one group with routine laboratory monitoring performed at postoperative day, POD, 1 and 3, lab group, and another group without routine laboratory monitoring, control group. The study's primary endpoint was the overall impact of routine laboratory monitoring. The secondary endpoints were evaluation of patients with complications. Results. The population in the two groups were similar in terms of demographic and intraoperative data. There was a statistical difference between the two groups in terms of length of stay, 5.7 days in the lab group and 3.5 days in the control group, p less than 0.001. There were 19 complications, 6.0%, in the lab group and 5 complications in the control group, 3.5%, p equals 0.25. A cutoff C-reactive protein level of 46.3 mg/L was found to be significant, p equals 0.006. In the lab group, 9 patients, 2.9%, required readmission versus 3 patients, 2.0%, in the control group, p equals 0.62. Conclusion. The interest of routine laboratory monitoring after SG seems limited. Routine laboratory monitoring alone is not associated with earlier diagnosis of complications. This routine monitoring is associated with an increase of stay in hospital. Improvement of triglyceride glucose index following bariatric surgery, a systematic review and meta-analysis. Background. Bariatric surgery is an effective intervention for the management of severe obesity and its associated comorbidities, including metabolic abnormalities. This meta-analysis aimed to evaluate the impact of bariatric surgery on the triglyceride glucose (TIG) index, a novel marker of insulin resistance and metabolic syndrome. Methods. A systematic search was conducted in Embase, PubMed, Web of Science, and Scopus. The meta-analysis was performed using Comprehensive Meta-Analysis, CMA, v4 software. The overall effect size was determined by a random effects meta-analysis and the leave one out approach. Results: a total of 9 trials, including 1,620 individuals, confirmed a significant reduction in TIG following bariatric surgery. Weighted mean difference, WMD, minus 0.770, 95% C minus 1.006, minus 0.534, P less than 0.001. In a sub-analysis according to the type of bariatric surgery, there was a significant reduction in TIG index for Roux-en-Y gastric bypass, WMD minus 0.775, 95% C minus 1.000, minus 0.550, P less than 0.001, and sleeve gastrectomy, WMD minus 0.920, 95% C minus 1.368, minus 0.473, P less than 0.001. In a sub-analysis according to the follow-up duration, there was similarly a significant reduction in TIG index for both less than 12 months, WMD minus 1.645, 95% C minus 2.123, minus 1.167, P less than 0.001, and greater than or equal to 12 months follow-up, WMD minus 0.954, 95% C minus 1.606, minus 0.303, P less than 0.001. Conclusion: the results of this meta-analysis demonstrated a significant reduction in the TIG index following bariatric surgery, indicating improved insulin sensitivity and metabolic health. These findings highlight the potential of bariatric surgery as a valuable therapeutic option for individuals with obesity and its metabolic consequences. Improvement of triglyceride glucose index following bariatric surgery, a systematic review and meta-analysis. Background: bariatric surgery is an effective intervention for the management of severe obesity and its associated comorbidities, including metabolic abnormalities. This meta-analysis aimed to evaluate the impact of bariatric surgery on the triglyceride glucose (TIG) index, a novel marker of insulin resistance and metabolic syndrome. Methods: a systematic search was conducted in Embase, PubMed, Web of Science, and Scopus. The meta-analysis was performed using Comprehensive Meta-Analysis (CMA) v4 software. The overall effect size was determined by a random effects meta-analysis and the leave one out approach. Results: a total of 9 trials, including 1,620 individuals, confirmed a significant reduction in TIG following bariatric surgery. Weighted mean difference, WMD, minus 0.770, 95% C minus 1.006, minus 0.534, P less than 0.001. In a sub-analysis according to the type of bariatric surgery, there was a significant reduction in TIG index for Roux-en-Y gastric bypass, WMD minus 0.775, 95% C minus 1.000, minus 0.550, P less than 0.001, and sleeve gastrectomy, WMD minus 0.920, 95% C minus 1.368, minus 0.473, P less than 0.001. In a sub-analysis according to the follow-up duration, there was similarly a significant reduction in TIG index for both less than 12 months, WMD minus 1.645, 95% C minus 2.123, minus 1.167, P less than 0.001, and greater than or equal to 12 months follow-up, WMD minus 0.954, 95% C minus 1.606, minus 0.303, P less than 0.001. Conclusion: the results of this meta-analysis demonstrated a significant reduction in the TIG index following bariatric surgery, indicating improved insulin sensitivity and metabolic health. These findings highlight the potential of bariatric surgery as a valuable therapeutic option for individuals with obesity and its metabolic consequences. Evaluating the impact of enhanced recovery after surgery protocols on surgical outcomes following bariatric surgery, a systematic review and meta-analysis of randomized clinical trials. Background: enhanced recovery after surgery, ERAS programs are evidence-based care improvement processes for surgical patients, which are designed to decrease the impact the anticipated negative physiological cascades following surgery. Aim: to perform a systematic review and meta-analysis of randomized clinical trials, RCTs, to evaluate the impact of ERAS protocols on outcomes following bariatric surgery compared to standard care, SC. Methods: a systematic review was performed in accordance with PRISMA guidelines. Meta-analysis was performed using Review Manager version 5.4. Results: 6 RCTs including 740 patients were included. The mean age was 40.2 years, and mean body mass index was 44.1 kg/m². Overall, 54.1% underwent Roux-en-Y gastric bypass surgery, 740, and 45.9% sleeve gastrectomy, 3,700. Overall, patients randomized to ERAS programs had a significant reduction in nausea and vomiting, odds ratio or 0.42, 95% confidence interval, C 0.19 to 0.95, P equals 0.040, intraoperative time, mean difference, MD, 5.40, 95% C, 3.05 to 7.77, P less than 0.001, time to mobilization, MD, minus 7.78, 95% C, minus 5.46 to minus 2.10, P less than 0.001, intensive care unit stay, ICUS, MD, 0.70, 95% C, 0.13 to 1.27, P equals 0.020, total hospital stay, THS, MD, minus 0.42, 95% C, minus 0.69 to minus 0.16, P equals 0.002, and functional hospital stay, FHS, MD, minus 0.60, 95% C, minus 0.98 to minus 0.22, P equals 0.002, compared to those who received SC. Conclusion: ERAS programs reduce postoperative nausea and vomiting, intraoperative time, time to mobilization, ICUS, THS, and FHS compared to those who received SC. Accordingly, ERAS should be implemented, where feasible, for patients indicated to undergo bariatric surgery. Evaluating the impact of enhanced recovery after surgery protocols on surgical outcomes following bariatric surgery, a systematic review and meta-analysis of randomized clinical trials. Background: Enhanced recovery after surgery, ERAS, programs are evidence-based care improvement processes for surgical patients, which are designed to decrease the impact the anticipated negative physiological cascades following surgery. Aim: to perform a systematic review and meta-analysis of randomized clinical trials, RCTs, to evaluate the impact of ERAS protocols on outcomes following bariatric surgery compared to standard care, SC. Methods: a systematic review was performed in accordance with PRISMA guidelines. Meta-analysis was performed using Review Manager version 5.4. Results: 6 RCTs including 740 patients were included. The mean age was 40.2 years, and mean body mass index was 44.1 kg/m². Overall, 54.1% underwent Roux-en-Y gastric bypass surgery, 740, and 45.9% sleeve gastrectomy, 3,700. Overall, patients randomized to ERAS programs had a significant reduction in nausea and vomiting, odds ratio or 0.42, 95% confidence interval, C 0.19 to 0.95, P equals 0.040, intraoperative time, mean difference, MD, 5.40, 95% C, 3.05 to 7.77, P less than 0.001, time to mobilization, MD, minus 7.78, 95% C, minus 5.46 to minus 2.10, P less than 0.001, intensive care unit stay, ICUS, MD, 0.70, 95% C, 0.13 to 1.27, P equals 0.020, total hospital stay, THS, MD, minus 0.42, 95% C, minus 0.69 to minus 0.16, P equals 0.002, and functional hospital stay, FHS, MD, minus 0.60, 95% C, minus 0.98 to minus 0.22, P equals 0.002, compared to those who received SC. Conclusion. A.I.O programs reduce postoperative nausea and vomiting, intraoperative time to mobilization, ICUS, THS, and FHS compared to those who received SC. Accordingly, A.I.O should be implemented, where feasible, for patients indicated to undergo bariatric surgery. Evaluating the impact of enhanced recovery after surgery protocols on surgical outcomes following bariatric surgery, a systematic review and meta-analysis of randomized clinical trials. Background. Enhanced recovery after surgery, ERAS, programs are evidence-based care improvement processes for surgical patients, which are designed to decrease the impact the anticipated negative physiological cascades following surgery. Aim. To perform a systematic review and meta-analysis of randomized clinical trials, RCTs, to evaluate the impact of A.I.O protocols on outcomes following bariatric surgery compared to standard care, SC. Methods. A systematic review was performed in accordance with PRISMA guidelines. Meta-analysis was performed using Review Manager version 5.4. Results. 6 RCTs including 740 patients were included. The mean age was 40.2 years, and mean body mass index was 44.1 kg/m2. Overall, 54.1% underwent Roux-en-Y gastric bypass surgery, 740, and 45.9% sleeve gastrectomy, 3,700. Overall, patients randomized to A.I.O programs had a significant reduction in nausea and vomiting, odds ratio or 0.42, 95% confidence interval, C 0.19 to 0.95, P equals 0.040, intraoperative time, mean difference, MD, 5.40, 95% C, 3.05 to 7.77, P less than 0.001, time to mobilization, MD, minus 7.78, 95% C, minus 5.46 to minus 2.10, P less than 0.001, intensive care unit stay, ICUS, MD, 0.70, 95% C, 0.13 to 1.27, P equals 0.020, total hospital stay, THS, MD, minus 0.42, 95% C, minus 0.69 to minus 0.16, P equals 0.002, and functional hospital stay, FHS, MD, minus 0.60, 95% C, minus 0.98 to minus 0.22, P equals 0.002, compared to those who received SC. Conclusion. A.I.O programs reduce postoperative nausea and vomiting, intraoperative time to mobilization, ICUS, THS, and FHS compared to those who received SC. Accordingly, A.I.O should be implemented, where feasible, for patients indicated to undergo bariatric surgery. Next article is from Journal of the American College of Surgeons. National Trends and Clinical Outcomes After Scooter Injury in the U.S., 2016 to 2020. Background. In recent years, the adoption of electric scooters has been accompanied by a surge of scooter-related injuries in the U.S., raising concerns for their severity and associated healthcare costs. This study aimed to assess temporal trends and outcomes of scooter-related hospital admissions compared with bicycle-related hospitalizations. Study design. This was a retrospective cohort study using the 2016 to 2020 national inpatient sample for patients younger than 65 years who were hospitalized after bicycle and scooter-related injuries. The trauma mortality prediction model was used to quantify injury severity. The primary outcomes of interest were temporal trends of micromobility injuries. In hospital mortality, rates of long bone fracture, traumatic brain injury, paralysis, length of stay, hospitalization costs, and non-home discharge were secondarily assessed. Results. Among 92,815 patients included in the study, 6,125, 6.6%, had scooter-related injuries. Compared with patients with bicycle-related injuries, patients with scooter-related injuries were more commonly younger than 18 years, 26.7% versus 16.4%, p less than 0.001, and frequently underwent major operations, 55.8% versus 48.1%, p less than 0.001. After risk adjustment, scooter-related injuries were associated with greater risks of long bone fracture, adjusted odds ratio 1.40, 95% C 1.15 to 1.70, and paralysis, adjusted odds ratio 2.06, 95% C 1.16 to 3.69, compared with bicycle-related injuries. Additionally, patients with bicycle or scooter-related injuries had comparable index hospitalization durations of stay and costs. Conclusions. The prevalence and severity of scooter-related injuries have significantly increased in the U.S., thereby attributing to a substantial cost burden on the healthcare system. Multidisciplinary efforts to inform safety policies and enact targeted interventions are warranted to reduce scooter-related injuries. Association of Neighborhood Deprivation and Transplant Center Quality with Liver Transplantation Outcomes. Background. Social determinants of health can impact the quality of liver transplantation, LT, care. We sought to assess whether the association between neighborhood deprivation and transplant outcomes can be mitigated by receiving care at high-quality transplant centers. Study design. In this population-based cohort study, patients who underwent LT between 2004 and 2019 were identified in the Scientific Registry of Transplant Recipients. LT recipient neighborhoods were identified at the county level and stratified into quintiles relative to Area Deprivation Index, ADI. Transplant center quality was based on the Scientific Registry of Transplant Recipients 5-tier ranking using standardized transplant rate ratios. Multivariable Cox regression was used to assess the relationship between ADI, hospital quality, and post-transplant survival. Results. A total of 41,333 recipients, median age, 57.0, 50.0 to 63.0, years, 27,112, 65.4%, male, met inclusion criteria. Patients residing in the most deprived areas were more likely to have non-alcoholic steatohepatitis, be Black, and travel further distances to reach a transplant center. On multivariable analysis, post-LT long-term mortality was associated with low versus high-quality transplant centers, hazard ratio, HR, 1.19, 95% C 1.07 to 1.32, as well as among patients residing in high versus low ADI neighborhoods, HR 1.25, 95% C 1.16 to 1.34, both p less than or equal to 0.001. Of note, individuals residing in high versus low ADI neighborhoods had a higher risk of long-term mortality after treatment at a low quality, HR 1.31, 95% C 1.06 to 1.62, p equals 0.011, versus high quality, HR 1.12, 95% C 0.83 to 1.52, p equals 0.471, LT center. Conclusions. LT at high-quality centers may be able to mitigate the association between post-transplant survival and neighborhood deprivation. Investments and initiatives that increase access to referrals to high-quality centers for patients residing in higher deprivation may lead to better outcomes and help mitigate disparities in LT. Next article is from Journal of Trauma and Acute Care Surgery. A heterogeneous population of extracellular vesicles mobilized to the alveoli post-injury. Background. Acute lung injury and subsequent resolution following severe injury are coordinated by a complex lung microenvironment that includes extracellular vesicles, EVs. We hypothesize that there is a heterogeneous population of EVs recruited to the alveoli post-injury and that we could identify specific immune-relevant mediators expressed on bronchoalveolar lavage, BAL, EVs as candidate biomarkers of injury and injury resolution. Methods. Mice underwent 30% TBSA burn injury and ball fluid was collected 4 hours post-injury and compared with sham. Extracellular vesicles were purified and single vesicle flow cytometry, VFC, was performed using fluorescent antibodies to quantify the expression of specific cell surface markers on individual EVs. Next, we evaluated human ball specimens from injured patients to establish translational relevance of the mouse VFC analysis. Human ball was collected from intubated patients following trauma or burn injury, EVs were purified, then subjected to VFC analysis. Results: a diverse population of EVs were mobilized to the alveoli after burn injury in mice. Quantitative ball VFC identified significant increases in macrophage-derived CD44+ EVs, pre-injury, 10.8% versus post-injury, 13%, p less than 0.05, and decreases in IL-6 receptor alpha, CD126, EVs, pre-injury, 19.3% versus post-injury, 9.3%, p less than 0.05. Bronchoalveolar lavage from injured patients also contained a heterogeneous population of EVs derived from myeloid cells, endothelium, and epithelium sources, with CD44+ EVs being highly detected. Conclusion: injury causes mobilization of a heterogeneous population of EVs to the alveoli in both animal models and injured patients. Defining EV release after injury will be critical in identifying diagnostic and therapeutic targets to limit post-injury acute lung injury. Next article is from the American Journal of Surgery. Scoping review of the second victim syndrome among surgeons, understanding the impact, responses, and support systems. Background: it is thought that 50% of healthcare providers experience second victim syndrome, SVS, in the course of their practice. The manifestations of SVS varies between individuals, with potential long-lasting emotional effects that impact both the personal lives and professional clinical practice of affected persons. Although surgeons are known to face challenging and high-stress situations in their profession, which can increase their vulnerability to SVS, majority of studies and reviews have focused squarely on non-surgical physicians. Methods: this scoping review aimed to consolidate existing studies pertaining to a surgeon's experience with SVS by broadly examining the prevalence and impact, identifying the types of responses, and evaluating factors that could influence these responses. The scoping review protocol was guided by the framework outlined by Arksey and O'Malley and ensuing recommendations made by Levac and colleagues. 3 databases, Medline, Embase and Cochrane Library, were searched from inception till March 19, 2023. Results: a total of 13 articles were eligible for thematic analysis based on predefined inclusion criteria. Effects of SVS were categorized into psychological, physical and professional impacts, of which psychological and professional impacts were particularly significant. Factors affecting the response were categorized into complication type, surgeon factors and support systems. Conclusion: SVS adds immense psychological, emotional and physical burden to the individual surgeon. There are key personal, interpersonal and environmental factors that can mitigate or exacerbate the effects of SVS, and greater emphasis needs to be placed on improving availability and access to services to help surgeons at risk of SVS. Adrenalectomy approach and outcomes according to surgeon volume. Background: this study assessed the relationship between surgeon volume, operative management, and resource utilization in adrenalectomy. Methods: isolated adrenalectomies performed within our health system were identified, 2016 to 2021. High-volume surgeons were defined as those performing greater than or equal to 6 cases/year. Outcomes included indication for surgery, perioperative outcomes, and costs. Results: of 476 adrenalectomies, high-volume surgeons, N equals 3, performed 394, while low-volume surgeons, N equals 12, performed 82. High-volume surgeons more frequently operated for pheochromocytoma, 19% versus 16%, p less than 0.001, and less frequently for metastasis, 6.4% versus 23%, p less than 0.001, more frequently used laparoscopy, 95% versus 80%, p less than 0.001, and had lower operative supply costs, $1,387 versus $1,636, p equals 0.037. Additionally, laparoscopic adrenalectomy was associated with shorter length of stay, minus 3.43 days, p less than 0.001, lower hospitalization costs, minus $72,417, p less than 0.001, and increased likelihood of discharge to home, or 17.03, p equals 0.008. Conclusions. High-volume surgeons more often resect primary adrenal pathology and utilize laparoscopy. Laparoscopic adrenalectomy is, in turn, associated with decreased healthcare resource utilization. To report Hounsfield units or not, there is no question. Introduction. Most adrenal incidentalomas are not appropriately evaluated. Reporting the mass in the radiology report summary and providing recommendations in the report can positively impact evaluation. This study evaluated the effect of reporting Hounsfield units who on adrenal incidentaloma follow-up. Methods. Patients with adrenal incidentalomas identified on non-contrast CT scan from 2015 to 2020 at a tertiary care institution were studied. Chart review was conducted. Patient and imaging characteristics were compared between patients who did and did not have WHO reported. Outcomes of interest were 1 outpatient referral, 2 biochemical evaluation, and 3 dedicated imaging if appropriate. Multivariate analysis determined the impact of WHO reporting in the summary and provision of recommendations on the outcomes. Results. 363 patients were studied, 36.9% had WHO reported. When WHO were used in addition to recommendations and reporting in the summary, the likelihood of outpatient referral increased from 10.1 to 32.6-fold, 95% C7.7 to 138.1, p less than 0.001. Similarly, the likelihood of biochemical workup increased from 2.5 to 7.8-fold, 95% C2.5 to 24.1, p less than 0.001. Conclusion. Recording adrenal incidentaloma WHO on non-contrast CT scans was associated with increased rates of outpatient referral and biochemical workup. Is state trauma funding associated with mortality among injured hospitalized patients? Background. We sought to quantify the association between state trauma funding and 1. In-hospital mortality and 2. Transfers of injured patients. Methods. We conducted an observational cross-sectional study of states with publicly available trauma funding data. We analyzed in-hospital mortality using linked data from the nationwide inpatient sample, NIS, American Hospital Association, AHA Annual Survey, and these State Department of Public Health trauma funding data. Results. A total of 594,797 injured adult patients were admitted to acute care hospitals in 17 states. Patients in states with greater than $1 per capita state trauma funding had 0.82, 95% C, 0.78 to 0.85, p less than 0.001, decreased adjusted odds of in-hospital mortality compared to patients in states with less than $1 per capita state trauma funding. Conclusions. Increased state trauma funding is associated with decreased adjusted in-hospital mortality. Subtotal versus total cholecystectomy for difficult gallbladders, a systematic review and meta-analysis. Introduction. With severely inflamed gallbladders, laparoscopic cholecystectomy can be difficult and may require procedures like subtotal cholecystectomy, SC. Few studies exist comparing SC and total cholecystectomy, TC, in the setting of severe biliary inflammation. This meta-analysis aims to compare SC and TC for difficult gallbladders. Methods. Medline Ovid, Embase Ovid, and Sinal were searched, including only studies comparing SC to TC for difficult gallbladders. Primary outcome was CBD injury. Secondary outcomes included bile leak, duodenal injury, retained stone, bleeding, intra-abdominal collection, wound infection, reoperation, and mortality. Results. 10 studies were included. Compared to TC, SC significantly lowered the risk for a CBD injury, 0% versus 1.6%, RR 0.30, 95% C 0.10 to 0.87, but increased risk of bile leaks, RR 3.5, 95% C 1.79 to 6.84, postoperative ERCP, RR 2.86, 95% C 1.53 to 5.35, intra-abdominal collections, RR 2.55, 95% C 1.32 to 4.93, and reoperation, RR 2.92, 95% C 1.14 to 7.47. Conclusion: SC is a reasonable alternative to difficult gallbladders that may decrease the risk of CBD injuries. Knowing both approaches is crucial to manage the difficult gallbladder while minimizing harm. Further studies are needed to understand the value of SC for difficult cholecystectomy. Next article is from World Journal of Surgery. Differences in trauma care between district and regional hospitals and impact of a trauma intake form with decision support prompts in Ghana, a step-wedge cluster randomized trial. Background: we sought to determine the achievement of key performance indicators, KPIs, of initial trauma care at district, first level, and regional, second level, hospitals in Ghana and to assess the effectiveness of a standardized trauma intake form, TIF, to improve care. Methods: a step-wedge cluster randomized trial was performed with direct observations of trauma management before and after introducing the TIF at emergency units of 8 hospitals for 17.5 months. Differences in KPIs were assessed using multivariable logistic regression and generalized linear mixed regression. Results: management of 4,077 patients was observed, 30% at regional and 70% at district hospitals. 8 of 20 KPIs were performed significantly more often at regional hospitals. TIF improved care at both levels. 14 KPIs improved significantly at district and 8 KPIs improved significantly at regional hospitals. After TIF, regional hospitals still performed better with 18 KPIs being performed significantly more often than district hospitals. After TIF, all KPIs were performed in greater than 90% of patients at regional hospitals. Examples of KPIs for which regional performed better than district hospitals after TIF included: assessment for oxygen saturation, 83% versus 98%, and evaluation for intra-abdominal bleeding, 82% versus 99%, all p less than 0.001. Mortality decreased among seriously injured patients, injury severity score greater than or equal to 9 at both district, 15% before versus 8% after, p equals 0.04, and regional, 23% versus 7%, p equals 0.004, hospitals. Conclusions: TIF improved care and lowered mortality at both hospital levels, but KPIs remained lower at district hospitals. Further measures are needed to improve initial trauma care at this level. Persistent disparities between trauma center types in the management of children with high-grade blunt splenic injuries. Background: in the early 2000s, substantial variations were reported in the management of pediatric patients with blunt splenic injury, BSI. The purpose of this study was to assess the recent trends and disparities between different types of trauma centers. We hypothesized that there would be persistent disparities despite decreased trends in the rate of splenectomy. Methods: this is a retrospective cohort study using the American College of Surgeons Trauma Quality Improvement Program database. We included patients, aged less than or equal to 18 years, with high-grade BSI, abbreviated injury scale 3 to 5, between 2014 and 2021. The patients were divided into 3 groups based on trauma center types: adult trauma centers, ATCs, mixed trauma centers, MTCs, and pediatric trauma centers, PTCs. The primary outcome was the splenectomy rate. Logistic regression was performed to evaluate the association between trauma center types and clinical outcomes. Additionally, the trends in the rate of splenectomy at ATCs, MTCs, and PTCs were evaluated. Results: a total of 6,601 patients with high-grade BSI were included in the analysis. Overall splenectomy rates were 524, 17.5%, 448, 16.3%, and 32, 3.7%, in the ATC, MTC, and PTC groups, respectively. ATCs and MTCs had significantly higher splenectomy rates compared to PTCs, ATCs, or equals 5.72, 95% C equals 3.78 to 8.67, and P less than 0.001 and MTCs, or equals 4.50, 95% C equals 2.97 to 6.81, and P less than 0.001, while decreased trends in the splenectomy rates were observed in ATCs and MTCs, ATCs, or equals 0.92, 95% C equals 0.87 to 0.97, and P equals 0.003 and MTCs, or equals 0.92, 95% C equals 0.87 to 0.98, and P equals 0.013. Conclusions. This study suggested persistent disparities between different trauma center types in the management of children with high-grade BSI. Quadratus lumborum block versus transversus abdominis plane block for inguinal hernia repair, a systematic review and meta-analysis with trial sequential analysis. Introduction. Postoperative pain management is crucial for patient recovery with quadratus lumborum block, QLB, and transversus abdominis plane block, TAPB, emerging as potential techniques. We aim to compare the analgesic efficacy of QLB and TAP in patients undergoing inguinal hernia repair. Methods. We performed a systematic review of Cochrane, Embase, and Medline databases to identify randomized controlled trials comparing QLB and TAP in patients undergoing inguinal hernia repair. Outcomes included postoperative pain and opioid consumption. Statistical analysis was performed using RevMan 5.4. The review protocol was registered at Prospero, CRD 42023445513. Results. We included 5 RCTs encompassing 255 patients. QLB was associated with a significant decrease in postoperative pain, MD-0.45, 95% C-0.75 to -0.14, and P equals 0.004, I2 equals 94%. However, we found no difference in 24-hour opioid consumption between QLB and TAP groups. Conclusion. QLB may offer superior pain reduction. However, its effect on opioid consumption remains unclear. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.